Appreciate it. And we are so excited to have our next presenter with us. Dr. Stephen Caldwell is a professor of medicine, nephrology, electives director of UME MD program of the Faculty of Medicine at the University of Alberta, and honorary professor at St. Andrews and Edinburgh Universities. Dr. Caldwell graduated from Edinburgh University and from St. Andrews University. He also attended Queen's University and holds an honors Bachelor's of Science from the University of Toronto. He serves as the student mentor for the St. Andrews Edinburgh Alberta International Medical Program. Dr. Caldwell is the director of the Polycystic Kidney Disease Clinic at the University of Alberta and is also an examiner for the Medical Council of Canada, and he examines for the Royal College of Physicians and Surgeons of Canada and is a PACES examiner for Edinburgh and London. He is also a fellow of the Royal Society of Medicine. We are so thankful for him to take time out of his very busy schedule to join us. And so I turn it over to Dr. Caldwell. Thank you.
Well, thank you very much. I'm hoping you can see and hear me okay. It's a great pleasure to be here and talk to you about one of my passions and my involvement with polycystic kidney disease. I'm just going to share my screen with you now, and hopefully you'll be able to see my presentation. Can you just confirm that you can see that?
Yeah. All good. Thank you.
Terrific. So like I said, today we're going to be sort of patient-focused and family-focused and talk about what living with autosomal dominant polycystic kidney disease is. My own interest comes from a direct family connection of polycystic kidney disease. In fact, this is a picture of my dad. This is my dad, John Caldwell. He passed away when he was 66, quite young, and he had autosomal dominant polycystic kidney disease. He was diagnosed early on and started on peritoneal dialysis in 1980. He spent 4 years on peritoneal dialysis and then changed to hemodialysis for the remainder of his life. And I grew up with a father on dialysis and end-stage renal failure. So it was my stimulus and I think my reason for becoming a nephrologist and for having an interest in polycystic kidney disease. I didn't always want to be a nephrologist. I actually started off life as a neonatologist. This is me back in just after medical school when I trained in Scotland. These were the first 2 premature twins that I ever had the pleasure of looking after. They were in hospital for 6 months. And this was the day they were being sent home, and the mother decided she only wanted me to carry them out to the car. So we took this photograph for posterity. The photograph on the right is the old hospital that I worked in to look after these infants. It was called Rotten Row, their Glasgow Royal Maternity Hospital. And the neonatal intensive care unit was that glass building on the roof of the building. It was an afterthought for the obstetrics hospital. And so we took care of these kids in a bit of a greenhouse. That's a picture of me in the background there, waiting for the baby to be delivered and take them to the neonatal intensive care unit. That old hospital is gone now and torn down, and they made a park in the site where the Glasgow Royal Maternity Hospital was, the Rotten Row. And to commemorate all the babies that were born in that hospital and all the babies that didn't survive, the memorial in that hospital is a large diaper pin that you can see in the photograph there. Back to my family connection, this is my family around 1880. This is my great-grandfather and my great-grandmother. And the baby in this picture is actually my grandfather. And we know that several members of this family had polycystic kidney disease from medical records. My great-grandfather did, my great-uncles, 2 of my great-uncles, and 1 of my great-aunts, and my grandfather all had polycystic kidney disease. This is my family pedigree. My grandfather was Joseph Caldwell, and he was definitely affected. We know that his death certificate suggested uremia. And my own father was affected, as I've said. He had 2 sisters, and they were, neither of which are affected. They're both in their 70s and 60s and 70s, and they're unaffected. So all of their children are unaffected. Now, it may surprise you to know that I took a long time to get enough courage to go and be tested and be diagnosed for myself. It was many years before I racked up the courage. I think a little knowledge is a dangerous thing sometimes, and my medical knowledge said there wasn't very much I could do about a diagnosis of polycystic kidney disease, so I decided it might be easier living with it, not knowing, than knowing and waiting for something to happen. So in my career, I was involved with all of my father's nephrologists. These are the people that looked after my father and came to be my mentors when I decided to start training as a nephrologist. Most of them in Toronto and quite famous in the nephrology world. Dr. Oriopoulos is a pioneer in peritoneal dialysis, as is Dr. Joanne Bargman, and Dr. Piratos was a pioneer in kidney transplantation. Dr. Aldal looked after my dad, and so did Dr. Peter Blake, whom I worked with when I first came to Edmonton. He was the nephrology fellow when I first arrived in Edmonton in 1991. So I came to Canada from Scotland, having been recruited by Dr. Halloran, who was the chair of the department at that time. And when I first came, I realized that the diagnosis that was in my family needed to be looked into. Before I got the courage to be tested, though, I realized that insurance would be a big problem. Life insurance, mortgage insurance, long-term disability insurance. Any of the patients out there who are living with polycystic kidney disease know the challenges that there can be in getting insurance. So I was able to shop around as a young man and find insurance companies that didn't ask me anything about family history and insure myself up to the hilt before I would have the courage to go and get a diagnosis. Marriage came along, and I intended that I would get tested if we got married. And before I could get tested, that marriage sort of didn't last very long, 22 glorious months. And so I never got tested again there. I was no longer married. But then I got married a second time, and before too long, children came along, and I started to feel the weight of responsibility and perhaps guilt for not being tested for a long time, and now having children to worry about had I maybe passed on the inherited condition to my children. I'll come back to my own testing in just a minute, but let's talk a little bit in more general terms about polycystic kidney disease and life with it. Just a step back for any of you who may not be familiar. The roles of the kidneys in your general health, they are the big filters of the body, and they filter everything and then fine tune that filter to decide what to hang on to. The other things that they do are important for red blood cell production through a hormone called erythropoietin. They're the major organ that helps to control your blood pressure, and you may be surprised to find that they're a major organ in the maintenance of both bone and calcium metabolism and health. So what is polycystic kidney disease, or ADPKD? Well, it's a genetically inherited disease. It's very common, you might be surprised to find. It affects about 1 in 500 people, although new cases can occur without an inheritance pattern. As I tell those kind of patients, any new genetic disease has to start somewhere in a family, and sometimes we identify the first member of a family that has it. But it's over the course of many years, 10, 20, 30 or more years, the kidneys become replaced by enlarging cysts, and the kidneys themselves get quite enlarged and can become very large and very cumbersome and symptomatic and uncomfortable. The cysts can range in size from very small to very large, and I've seen some kidneys that have come out looking the size of watermelons. They are made up of millions of tiny filtering units, the kidneys themselves, and when a cyst forms, those cysts get bigger and are in places where they start to block the flow of urine. And when they do that, they start to negatively affect the function of the kidneys. And that's why it may take many, many years for kidneys to fail, as more and more sections and more parts of the kidneys become blocked and start to lose their function. Some of the first signs that you may experience, high blood pressure is almost universal and usually starts quite early in life. If you have polycystic kidney disease, it's not uncommon to develop high blood pressure in your 20s or 30s and sometimes earlier. Blood in the urine or hematuria is a common presentation early, and an awareness of these enlarging kidneys with a feeling of heaviness or pain in the back or in your abdomen. Urinary tract infection is very common, and kidney stones are very common in polycystic kidney disease. However, it must be noted that many patients have absolutely no symptoms at all for their entire lives and don't have symptoms until their kidneys start to fail in later life. What else might you expect as the cysts continues to grow, sometimes increasing abdominal pain, and sometimes the kidneys become so large that they're noticeable to other individuals, that your friends and family might think you're putting on weight and getting a bit of a beer belly when it's actually the enlarging kidneys and the enlarging cysts. They may also develop in other organs, but the cysts that develop in other organs, primarily the liver, are rarely, if ever, concerning for affecting the function. So that while the cysts in the kidneys will eventually result in end-stage kidney failure, the cysts that form in the liver rarely cause any problems with liver other than discomfort and uncomfortable feeling in the abdomen. How do we diagnose it? Well, often it's diagnosed by accident when patients have radiological procedures like an ultrasound for some other reason, and it picks up cysts in the kidneys, and then they get referred to me. Sometimes it's the other way around, and patients are well aware, like I was, of their family history, and they ask to be screened for it. And depending on their age, an ultrasound can be the most effective tool in screening for polycystic kidney disease. More commonly now, if there's any doubt about the diagnosis, and you may be surprised to know that there is sometimes doubt about the diagnosis, even with a strong family history, we now are regularly doing genetic testing to determine not only if the abnormality is there, but which specific abnormality is there, so that we can determine if appropriate therapy for the same. There are two main genetic abnormalities for polycystic kidney disease, so-called PKD1 and PKD2. Most common is PKD1, and those patients usually progress to needing dialysis or a kidney transplant by the time they're in their late 50s or early 60s. But some families have a different abnormality, PKD2, a smaller number of families, and they often live their entire lives with cystic kidneys, but never needing dialysis or a transplant, or if they do, it's later in life in their 70s or their 80s. Even among people with the same genetic type, however, there can be a lot of difference. So if your father had polycystic kidney disease and ended up on dialysis in his 40s, that doesn't mean you might not make it till your 60s or 70s, or may never need it. The family trends are not reliable. The chances of inheriting it is exactly 50%. The inheritance is called autosomal dominant. The abnormal gene is on a regular one of your chromosomes, not a sex-related chromosome. So equal chance of getting it whether you're a male or female. And every child of an affected parent has a 50-50 chance of inheriting the same gene. And if they inherit that gene, they will express it and go on to have the presentation that I've described. So who should we screen for patients with polycystic kidney disease? Early detection in asymptomatic patients can allow us to be aware, get a better understanding to help people plan their families, lifestyle modifications, checking for blood pressure issues. And it's important to know if you're in a family where you may be considered for kidney donation. There are many reasons not to get screened. And as I said, personally, I felt at the time it was a lot easier not knowing whether I had this condition when I was 20, 30, or even 40, than it would be to live with that knowledge. Insurance acquisitions and things like that can certainly be something that would go into consideration of whether to get screened or not. Imaging, as I said, ultrasound, genetic testing, and if family members request it to speak to us, we can organize screening for families with polycystic kidney disease. So if you do not want to be screened for polycystic kidney disease and you don't want to know for sure, that shouldn't mean things should be ignored. You should still have regular checkups with your family doctor, regular urine tests to look for blood and protein, monitor your blood pressure, make healthy lifestyle choices, and be vigilant for any of the abnormalities that I've already described in polycystic kidney disease. What are some of the complications that can go along with polycystic kidney disease? Well, we've described most of the ones that are already directly related to your kidneys, but there are also several others that may not be related to your kidneys. Things like patients with polycystic kidney disease are at slightly higher risk of aneurysms, especially in the brain. They're at slightly higher risk of developing or having valvular heart problems. And both of those things are things that we screen for regularly when patients are first diagnosed and over the years that we care for them as well. Other things that are more common in polycystic kidney disease, I've mentioned liver cysts, but problems with the bowel, including diverticulosis and other cystic lesions elsewhere, are common. For optimal kidney health, it's fairly common sense type advice: maintaining a healthy weight, exercising and avoiding smoking, keeping your blood pressure well controlled. And in patients with polycystic kidney disease, we actually have considerably lower targets for blood pressure than the general population or even other patients with kidney disease, and ensuring that water intake is well maintained. Who's part of the team? Well, most recently, I've begun in around 2019, a specialist clinic in Edmonton called the Polycystic Kidney Disease Clinic. It's a multidisciplinary clinic where we specialize in all of the problems and challenges of dealing with polycystic kidney disease. And your family doctor can refer directly to our triage, and that your patients will be, and the patients will be seen by myself in the polycystic kidney disease. Or if you already have a nephrologist who would like assistance with the management of polycystic kidney disease, they can refer to us as well. The patient's perspective for after receiving the diagnosis, the Polycystic Kidney Disease Foundation of Canada has a website, and they have a wealth of material, educational and supportive, that can help dealing with this diagnosis in the early stages and for the entire course of your condition and dealing with yourselves and with your family. So I would strongly encourage you to contact the PKD Foundation of Canada. There is a local chapter here in Edmonton as well. The newly diagnosed discussion, we start thinking about things: how often you need to see your nephrologist and what other things you're at risk at. We've talked about that. Many families, many patients like myself didn't want to tell their families, and how to help them through those kind of family and social interactions. What lifestyle modifications may or may not be needed. And the question I get most often is, what about family planning and the genetics of the disease, and whether decisions about having children at all are something that polycystic kidney disease patients should consider. If family members want to be tested through genetic testing or ultrasound, we can help with that through the polycystic kidney disease as well, and recommendations even if they don't want to be tested for it. So living with polycystic kidney disease, we've talked about already the importance of a healthy lifestyle and managing and looking after and following all the potential complications of polycystic kidney disease. And that's the lifelong management that occurs long before end-stage renal failure and the consideration of dialysis or transplant happens. And that's why one of the reasons we've developed the Polycystic Kidney Disease Clinic here in Edmonton. For healthy choices, heart-healthy diet, general tips, the healthy lifestyle and healthy dietary consumption is all very straightforward. We do have our renal dietitians who help with the specific machinations for patients with polycystic kidney disease. And then when their kidney disease starts to advance, there are lots of dietary management and modifications that we need to consider. Exercise is something we don't restrict at all until cysts and kidneys are extremely large. Then we start to think about the possibility of limiting contact sports, especially with very large kidneys. How much water should you drink? There's lots of literature out there suggesting that tons of water or over excessive water may help delay the onset of polycystic kidney disease or the progression. And in some experiments that's been shown, but really the amount of water should just be a healthy amount, keeping up with your output and making sure you don't get dehydrated. There's been a lot of research, and one of the reasons I didn't find out about my own diagnosis for many years was because there wasn't really very much we could offer patients medically that would do anything to prevent or slow the progression of polycystic kidney disease. There is now, most recently, medication on the market in the form of a drug called tolvaptan that has great potential to slow down the progression. It is not a cure, and it won't change your ultimate outcome, but it might make it several years farther in the future than it would have been if you hadn't taken the medication. Tolvaptan was approved for use in Canada in 2015, and that's when I decided to go and get tested, because now there was medication and hope that things could be slowed down and positively affected in the polycystic kidney disease world. It's now been shown in 2017 that it definitely slows down the decline of kidney function, and is now approved in Canada for use in polycystic kidney disease to do just that. It's a medication that blocks a hormone called vasopressin, and we think that vasopressin is responsible for stimulating cyst number and cyst growth. And if you'll remember what I said before, the more cysts and the bigger they are, the more blockage and the more progression in kidney failure. By blocking that hormone, it may protect your kidneys and slow down the progress of polycystic kidney disease. Another effect is that it does increase your urine output. So a side effect is that it makes you pee quite a bit, but most patients learn to live with it. And I don't have any patients on tolvaptan that have decided to come off of it because they can't handle how much they're peeing. People most likely to benefit are those with a certain volume of cysts and that are rapidly deteriorating, have high blood pressure, and already the signs of effects on the kidney. It isn't for everybody, not yet approved for children under 18. It's not approved for a separate condition called autosomal recessive polycystic kidney disease, and it's certainly not approved for anyone after they have a kidney transplant. Monitoring your blood pressure is key throughout your lives, even if you don't have kidney disease, but more importantly when you do, and especially if you have polycystic kidney disease. Home blood pressure monitors are affordable and widely available, and you and your physician should definitely be looking at it. And as I said, we have slightly lower targets for polycystic kidney disease than even in other forms of kidney disease. It needs to be treated. There are lots of different medications, different classes of medications. Often you'll be on one or two or more, but ACE inhibitors or ARBs are probably the mainstay of blood pressure control in polycystic kidney disease. These are some of the examples that you may already be familiar with of ACE inhibitors. These are ARBs, and you may recognize some of the medications that you may already be on. Beta blockers are very effective blood pressure medications in kidney disease, as are calcium channel blockers and water pills or diuretics. There's pain that can go along with polycystic kidney disease as well, due to kidney stones and cyst infection and rupture, or just the very large size of the kidneys and cysts that you're carrying around. And one other benefit of tolvaptan in the studies were that it seems to lessen and relieve the pain and discomfort that's associated with polycystic kidney disease in many patients as well. Stones are common, as I said, with polycystic kidney disease, and that's where we bring in our colleagues from urology to try to help remove them if they become problematic and obstructive. And in my world, try to modify your biochemistry and your diet to prevent formation. Liver cysts are primarily seen in women because we think they're under the stimulus of estrogen. And so women get more liver cysts than males in polycystic kidney disease, but it's rare to see any problems with liver function, even when there's hundreds of cysts in the liver. Aneurysms are not uncommon in polycystic kidney disease. We screen for them at the time of diagnosis with MRI angiogram. And if negative, I repeat that screening every 5 years. If there's any suggestion of aneurysm, it's a quick referral to my colleagues in the neurosurgery department who specialize in that. And we have a close relationship, and they monitor as well. And it's rare that patients with aneurysms need surgery, but we do follow them very closely. Again, I would strongly recommend you visiting the Polycystic Kidney Disease Foundation of Canada's website to try to get all of this information at your fingertips. It's an excellent resource. Here are some of the questions that I get lots of times in my clinic, and you may see some of the questions that you're keen to ask as well. We probably don't have a lot of time to go over them all tonight, but I think at the end of this presentation, I do have some time for questions. I'll also provide my email address, and feel free to drop me a line with any questions you might have, and I can give you a better written answer in more detail. The long-term outlook is good. As kidney function progresses and cysts get bigger, we hope that the intervention with medications like tolvaptan and a lot of medications that are currently in research and coming down the pipeline that may have equal benefit may positively affect the progression. Early on in the case, no problems, and we just keep an eye on your blood tests and all of the other complications. The options, if your kidneys are no longer functioning, are the same for any patient with kidney failure: dialysis and transplantation and the various modalities. There are none of these options that are restricted for patients because of polycystic kidney disease, so every option is open to those patients as well. Dialysis is the machine type dialysis that I think we've alluded to in Dr. Panu's talk, and peritoneal dialysis. These are equivalent and are able to get rid of the wastes and excess fluid that comes with kidney failure. And the decision between the two is really a lifestyle one. Which form of dialysis may best fit into your lifestyle, considering employment, family, location, and activity. Transplantation is also the other modality of renal replacement therapy of choice. And we have some extra challenges in polycystic kidney disease because of the genetics and many family members that will need to be screened if they want to come forward to be considered as a donor. Transplant, I'll leave for, I think Dr. Cofield is coming on after me to talk about the experience in renal transplantation and the National Transplantation Program, which I'm sure she'll be talking about subsequent in the next presentation. So once again, there are innumerable resources for patients with polycystic kidney disease. The PKD Foundation of Canada and the USA, and the Kidney Foundation of Canada obviously plays a major role in education as well. There are some transplantation specific resources that you can see here, and I can provide this slide for reference if you want to quickly get any of these websites. Again, once again, stressing the PKD Foundation and the local chapter here in Edmonton. There's lots of things we could discuss with respect to long-term outlook discussion, and I'm happy to answer any questions, but I'm cognizant of time constraints tonight. So the big question was, when I finally went to have my test and find out if I did have, I went for an ultrasound at age 56. That's how long it took me to summon the courage. My father had ended up on dialysis at age 50. I was 56, and as I mentioned, there wasn't really any symptoms, but I wasn't sure. So I went for a transplant finally, and hold on. That's a copy of my transplant, and as you could probably see, that's a perfectly normal kidney. So I was very relieved to find out at age 56 that I didn't have it. And as a result, back to my family tree, since my father was affected and I'm not affected, it means that my children are 99.9% unlikely to be affected unless they become new mutations themselves. So it's now gone from my family, and that's a great thing. But the legacy of my dad is that I now work with polycystic kidney disease and try to help new patients, new families, and everyone affected. Hopefully you enjoyed the presentation, and I certainly have time for any questions you may have right now. I'm going to stop sharing my screen for a second here.
Thank you so much, Dr. Caldwell, for sharing your knowledge with us today and all the great information in terms of what we should be aware of. So like Dr. Caldwell mentioned, if anyone has any questions, feel free to unmute yourself and ask away.